the yield of information, which is very important as the practical examples and the best practice in clinical workflow is going to be my topic for the next few minutes. So initially, when we planned this session, actually we had a tie-up with EDON, and we wanted to go and do it in a three-dimensional way, especially for our participants who are going to attend the symposium. We thought, why not give a 3D display for them? But unfortunately, due to this pandemic, we are not able to do that. But still, since this is a recorded session, I would still advise you to go ahead, and if you have this video access in the future, you can still use your 3D glasses. There are some pictures which will actually have a good representation of how the 3D imaging will be. As Sir was pointing out, and Shweta was also covering, the slit lamp examination, we use 60D, 78D, 90D to get a stereoscopic evaluation of the optic disc. So this is one of my images taken at Satyan Eye Care when I was my fellow there. So you can see, as Sir rightly pointed out, when you use the slit to view the optic nerve, it's quite small in size. You may not really get a good view of the optic nerve size stereoscopically. The problem is the pupil needs to be at least 4 millimeter in diameter to have a good stereoscopic view of the optic nerve, the contour of the cupping depth, so and the vessels, how it is going to bionet and so on. And you need to have an eye magnification too in the slit lamp. And as Shweta pointed out, the clinical drawing, though fundus photography is taking leaps and bounds, clinical drawing is indispensable even today, because when you see a picture, you can still draw a good clinical drawing, and a picture from Beckers and Schaffers. As you can see here, this box here, from 6 months after, you can see the vessel is slightly bended. So even with clinical drawing, if you are going to have a good concentration, you will still get your reward. But the problem with clinical drawing is it's always a 2D diagrammatic rendering of a 3D structure, because we are drawing a 3D structure. But that doesn't serve the purpose, because isn't the clinical examination and documentation incomplete? Because the fundus diagrams are a 3D rendered model. It can't be represented 2D. It is something like an architecture of a building which has to be represented 3-dimensionally. So that is where no financial disclosure. The EDON True Color confocal scanner, as Sir was telling, as a big brother. So I also started with DRS and then now with EDON. The stereoscopic fundus capture is similar to the slit lamp in many ways. As you can see, in slit lamp, we use the magnification to view the disc. In the fundus capture, we have the zoom, and it's very comfortable if you take the LAN connection at your slit lamp. You can have your system near it and you can use the zoom. The principle of this particular technology is, it's quite simple. It takes two offset images. The two images are slightly offset from one another of the central nasal field, will be captured with automatic alignment and focus. There is a delay between the two shots in order to let the pupil recover. Otherwise, what happens is, bigger the pupil, better will be the stereopsis. If the pupil is small, then you don't really get a good image. Preferably, if you put a dilating drop, it will be better for stereopsis. But according to my knowledge in my practice, still without dilating also, this technology is able to give you a moderately good image in stereoscopic view also. So this is an example of an increased vertical cup disc ratio. So again, as I was saying, I wanted you all to experience this in a 3D way, but still the recording is there. I hope it will be accessed in the future. So you can click the 3D settings and take the image. You get two offset images. As you can see, the two offset images will be there. And once you use the 3D glasses, you can see the beautiful image, the bionetting sign, the cup's depth, every contour of the 3D optic nerve can be accessed. And this particular 3D glass has a lot of settings. It has a magnification factor. If you have a 3D TV, 3D PC, an iNotebook or an iPad, everything, you just need to alter your settings slightly and it gives you a good 3D view. As Satyan sir was pointing out, how do we set up the workflow? So myself and Satyan sir, we published a paper in the Indian Journal of Ophthalmology as to how the soft copy examination is very important for a glaucomatologist, because there may be 3 cabins, 4 cabins. So one single mission can give you relay for all the 4 cabins, and you can use the maximizing the yield of the fundus photograph. So you just need to use your, if you have a wireless web interface, then you can go for wireless, or you can use a local area network to establish the connection from the machine to your PC desktop so that the screen mirroring takes place. So I would recommend all the participants of this instruction course, if you have time, please do read this article. We have gone in a comical way and told it as an infinity tools. That is our gadgets. How are we going to link it in the gauntlet that you saw in the Marvel Cinematic movie? So this is our article. as Sir was telling on how land is having an impact in current practice. Because today we don't see ourselves taking soft copies. You can't waste your paper. You have to go green. And there is also the COVID factor. So it's better to go soft copy because there are droplet related transmissions taking place. So the soft copy is going to be one of the future aspects. And once you have set up a good LAN, this is a glaucomatic optic atrophy. Again, a video of the same. Once you take a 3D photograph of two offset images, you can appreciate the beautiful 3D image of this particular glaucomatic optic atrophy. Then we have a wedge defect. Take a 3D image. Just explore the 3D aspect of the fundus tools that you have, because 3D is the way to go, because 2D examination of a 3D structure is not the right way, as we saw in the diagrammatic rendering concept. This is an RNFL defect, an arcuate RNFL defect. So these are all practical examples that we all see in our day-to-day practice. The idea behind my talk is to give a 3D perspective. So hopefully I feel the participants may have your own 3D tools so that you can access to all these images in the future. And this is a bio-netting sign here where you can see the vessel having a bend at the edge of the cup. So again, you can use your zoom. You can go use your zoom, and you can have a beautiful three-dimensional rendering of the optic nerve. And this is a suspicious deep cup. So you can see the choroidal folds behind, and again, two offset images to give a beautiful 3D image. Use your glasses, view the image. A tilted disc with glaucomatous cupping. So again, that is another example of our glaucoma atlas, which we are working on. And finally, one particular question that every one of us will be having is when to take the stereo disc photographs for suspects or glaucoma patients. Take a baseline photograph at the time of initial visit, and then at every interval, maybe it may be 6 months or 1 year, according to your practice pattern, which the patient feels comfortable. We prefer at least once in a year will be better. And why fundus photographs? As you can see, side-by-side comparison is possible because glaucoma is an asymmetrical disorder. We always see the asymmetry between the right eye and left eye. Only when we compare two discs side by side, we really get the idea of what is the asymmetry, which we don't need to do the mental mapping in the mind, which you have with the 90. And always, another point that Shweta also pointed out, a cupping. This may be a 0.85 for another person, it may be 0.9 for another person. But when you have a tool, you can go as precise to reduce the intra-observer variability, so that the patient gets the benefit of doubt and he does not have different cupping at different visits, because manually we tend to make some errors, but digitally up to 2 digits, 0.88, it works wonders. So the risk profiling is very important. That is another aspect. A normal tension glaucoma, we may have a patient with a splint hemorrhage, as you can see here, with an inferior RNFL defect. Following up the patient with precision, the resolution of splint hemorrhages can be beautifully followed up. There are a lot of benefits by going with this. And as a glaucomatologist, last but not least, a holistic evaluation of comparing the cup with the structural damage with the functional damage. You can see that the superior notching of the optic nerve is compared with the polar analysis of the visual fields. So this also is applicable only with the technology of LAN, where you can be at your own comfortable place and access this. So approach holistically. Fundus, yes, we have our topic on fundus, but this is a very important take-home message because visual fields, IOP, gonioscopy, OCT and CCT are very important. The facts are in favor of stereoscopic fundus photograph. The sensitivity is up to 95, the specificity is up to 98, and stereoscopic disc photography has been shown to perform better for glaucoma screening than perimetry. Even certain studies have reported that. And the current relevance of stereoscopic fundus imaging, as every one of you will be having your own physical barriers. We have this one particular cubicle here, and you can see that we have positioned the fundus photograph here with the opening here for the patient to place their headrest and leg rest to have a comfortable examination. So this is just a teaser for my next talk, which I'll be talking on the quality of imaging too, as to how we have validated the study and we have published the data. So this, and as Shweta pointed out, we are living in the COVID era where there are two main difficulties. One is accidentally touching the patient's face or mask. Second is if you are a shield guy, where you have a shield in your face or something. Again, that is also going to cause a poor visualization of the fundus. So these are some challenges, and I'm just summing up. This is my last slide. So we started, as Sir was telling, not investment point of view. When you see 50 patients a day, and predominantly 35 patients are new patients, if you charge 100 rupees extra for a patient for fundus photograph, which we are actually implementing here, because we felt the non-contact procedure is much better, you may end up having a return of investment for DRS within 2 years. Again, no financial aspect, but this is something that is needed for a private practitioner at a very early stage. And we do have sessions on the artificial intelligence, which sir will be talking in detail as to how we are annotating the disc separately. You can see we have created our own tools as to how the cup disc and the peripapillary atrophy can be annotated separately. So far in literature, this concept has not been published, where we are validating the disc, PPA, the RNFL separately. That is something that myself and Satyen sir are working on. And last but not least, so this has really served as my COVID buddy, and I'm grateful to my mentor again. I've thanked him enough, but I keep on thanking him because he's the reason why I'm standing here. And thanks a lot once again, sir, for this wonderful opportunity. As I've taken glaucoma and I'm exploring all these technologies because of you. I would like to thank him and invite you.
Thank you so much, Prasanna, for our